Welcome to Hatching Creativity. This isn't just another behavioral health podcast. This is the place where thought leaders converge to talk about real-life challenges, breakthroughs, and pivotal aha moments. Hey, everybody. I'm really excited for today's guest, Dr. Annie Peters with NAATP, or NAATP, as some call it. Annie is a behavioral healthcare expert. She's been in this field for a long time, working with her current project now, FORSE. Annie, I'd love if you can talk a little bit just about yourself and your background and tell us about FORSE and what you're doing with FORSE.
I can. Great. Well, thanks, Mike. Thanks for having me. This is fun always to just chat about things of interest in the field and what we're doing and collaborations. Currently, I am the Director of Research and Education at NAATP, or the National Association of Addiction Treatment Providers. I've been in this role for 3 years now. I'm a clinical psychologist, and so most of my career was in clinical work. I started in 2006, Hazelden Betty Ford Foundation, worked there. It was just Hazelden then, and worked there for about 9 years, 8 years. Mostly did co-occurring disorders support of patients in both long-term outpatient settings and of course, in inpatient and residential treatment at Hazelden Betty Ford. And then I transitioned into their graduate school and was a assistant professor in their graduate school, helping people as they became addiction counselors. So that was a really fun component of my career. Then I moved to a treatment center in Colorado, Harmony Foundation, and was chief clinical officer there for 6 years. And then I joined the staff at NAATP. I was actually on the board when I was working at Harmony for a couple of years. I was on the board of NAATP. NAATP did a pilot study on treatment outcomes published in that 2019. And after that, they said, we really need to do this bigger scale and help treatment providers to do this work. So they brought me on board and we established the NAATP Foundation, which is the Foundation for Recovery Science and Education, which is what FORSE is. And so FORSE is it's a part of NAATP, but it's also a standalone 501c3 nonprofit. That was kind of a long intro, but
well, I got a lot of questions
about me and talk about FORSE, so I tried to fit it all in one.
You look at outcomes data and you speak with people about outcomes all the time. If you're asking me for my feedback, if we don't actively show what we're doing with the information that they're giving us, it becomes a waste of time for people. And that's really where compliance has sat for so long, is people are like, yeah, I'll do all of this, but you're not going to be able to use the information for anything. It's just too much of a hassle.
We're not looking at that stuff as a staff. And then the staff, the clinicians or the techs, can say, I think I might know part of why this is happening, that the team comes together and says, what are we doing that we could do better to improve? That's an outcome, is
absolutely
who's completing treatment, who's being well served by treatment, satisfied with treatment, and who isn't. Again, that reflection back and that analysis of the data, it's one thing to collect it all, but then to really get in there and make meaning of it and make change because of it, make process improvement because of our data. That's another thing.
For sure. I also find from my experience with this, that when you share it with the staff and you start reviewing the data with the staff, they feel very empowered. Totally. Right? They're like, oh, wow, this all makes sense. This lines up with this. This lines up with this. And now I see how this all impacts this, and we talk all the time. And I think you and I had a conversation about this last time about turnover and keeping staff on, right? Staffing shortage is huge right now. So being able to do something that helps your outcomes, it helps your business efficiency, and it keeps people engaged. It keeps your staff excited to be there. You walk around a conference, right? And you can go to a booth of ABC Treatment Center, and there's 3 people at the booth that work there. And you ask them about their center, and they say, oh, we're an evidence-based practice and we're this and we're that. And then, they pass you a brochure and you say, oh, good. What evidence are you looking at? And they'll rattle off a couple of different things. How often are you collecting this? And when are you reviewing it? And you'll get a set of answers, or you get the deer in the headlights look, usually one or the other, right? And you can go back like an hour later and talk to somebody else at that same booth who will give you a whole different set of answers.
Right. You'll think it's a
And,
different center.
yeah, and it's really hard because what I guess the point I'm getting at with it is that it's something that and good outcomes need to be pushed by leadership. And it all has to start at the top of the organization and really be working its way down consistently. As we have more tools to collect data, I think that there will be more use of it, and people are respecting it more now for sure.
Mm-hmm. Yeah, we all know we need to look at outcomes. We need to come to some kind of consensus on what that means and measure together, not like you said, not just one treatment center measuring what they think is important and then not comparing that to other treatment centers. Is if you're not measuring the same things as other treatment centers, then how do we know, how do you compare? So that's kind of a big part of with FORSE. We want to provide that opportunity for people to look at their outcomes by some type of definition compared to others, and so that they can start seeing differences and get some standardization. Someday we will have measures that everyone will measure these 5 things. They may be collected by a wearable device. They may be collected by blood. They may be collected by self-report. We're not sure yet.
As we're talking about data, and as you've had a chance to review the data collected from FORSE, what was the biggest surprise?
So what surprised me most in the data, I don't know if this was a surprise or not, because I knew it would happen, but essentially the amount of missing data, the amount of particularly even demographics and the amount of difference in those basic measures like length of engagement or medications, how those are recorded, ethnicity and race, gender. This is now, I would say about 75% of the treatment centers in FORSE are taking private insurance. And so they're not publicly funded, and they're not taking, Medicare, Medicaid and state funding and things like that. So they're not required to use very, very specific data points. Gender, I would say by and large, we're getting male, female, and other. Or, people have 50 options, or they use a free text, which clinically is ideal to say, how do you define your gender, and letting the person self-report, but then trying to compare
And
that.
aggregate that.
People are trying to be inclusive, and yet then how do we aggregate that and use that? So, that's not an outcome I was surprised by, but just the amount of variability and challenges we have in the health IT world, collecting measures. It's nice when we get just data from a PHQ-9, because, a depression screen, they're 9 standard questions and they don't change. Although we have had some sites that change standardized measures, which is a challenge. So I guess that was one thing that was surprising, how much, missing gender and race ethnicity data we had because of the differences in how people are recording it.
So when you say missing information, are you saying like people are just not completing this in their medical records?
Well, so we picked away at some of the reasons. A lot of times it's where it's completed in the medical record. So they might ask a question in an assessment that then doesn't make it onto a face sheet or something in the EMR, which is where the data point is pulled from. So in that case, it's sort of an EMR issue. It's a technology issue. Other times, when we talk to a treatment center, they'll say, well, we know their gender, or there's something assumed that somehow it gets from an assessment, or it's not specifically asked, or all the options aren't given, or something, and it's missing for another reason. We have some there's 2 data points, gender identity and birth sex or something, a sex assigned at birth. An EMR or a provider would default to birth gender if they didn't hadn't asked the gender identity question.
Right,
So
right,
they'd be pushing essentially gender assigned at birth when what we were asking for was the person's own self-identification of gender.
right.
Because that wasn't asked explicitly,
It
we were
affects
getting.
your data, of course.
Mhm. Yeah.
What I'd like to do, Annie, too, is we're working on this big project with Kipu right
Mhm.
now, where we're building out standardized documentation to meet state and accrediting body
Yep.
requirements. Because
Yep.
as you know, everybody creates their own EMR and
Yeah.
everybody wants to
Yeah.
customize it to their
Yeah.
own. And we've all recognized the
Yeah.
need for standardization.
Yeah.
I know they're one of the providers that, or one of
Yeah.
the software providers that has
Yep.
given this to you. I think it would be really valuable if we get together once we've created these forms for them
Yeah.
and we get an understanding of what documentation you need for
Yeah.
this, so that that can be one of the standardized
Right.
forms or questions or fields that will help you to be able to
Yeah.
get that. Because I think the information you're collecting is real valuable.
Yeah. Can you work on discharge type?
Sure.
Because here's another one. I was just looking at this yesterday and thinking, I need to write a blog about this or something. Is, discharge status, usually in healthcare, in a hospital or something, you're discharged to a disposition or setting. Like you're discharged to,
Mhm.
you're discharged to a long-term hospital, you're discharged, et cetera. They may indicate whether you completed your treatment or not, or you left against medical advice or something. But in addiction treatment, we use discharge type to talk about things like not just where they're going, because we don't just want to say they transferred, but we want to know, did they transfer to a place that had more psych services, or a place that had more
Sure.
medical care, or a place that was a different level of care, or something. We really want to know that, but then we also want to know why the person left. And unfortunately, a lot of sites use something like administrative discharge, or, even still use the term non-compliant. That, is a
Mhm.
patient not complying with the rules of the center. And there's been a lot written about that. You don't see that in an ER.
One of the things
So,
that we do in our software is we take the AMA, and we have AMAs tracked as incidents,
mhm,
and the AMA gets paired with the reason or reasons behind them leaving,
mhm,
who was their primary therapist, who was their
mhm,
case manager,
right.
right? How many times did they attempt to leave? A lot of times that's a staff training issue,
Yeah.
being able to interrupt an AMA. And then, of course, the social determinants of health, substance of choice, we find is when people actively use it this way, and it doesn't have to be in our system, it could be anywhere where you're tracking this. But if they look at it right and collect the information, they can go, oh, this primary therapist is an abstinence-based person, and this client just wanted to stop or slow down or
Yeah,
change their lifestyle, and you can really break up
totally.
how you can be better treating people. And people don't look at this, and it's hard because they are inundated
Yeah,
with so much. That's part of the problem with fee for service,
yeah,
is they're taking everybody that they can, and they miss opportunities to treat better
yeah,
because of that too.
yeah, yeah,
When you talk about the discharge type
yeah.
too, another thing that comes to mind is admissions. Where's this person coming from? Are they coming
Mhm,
from prison, or are they
yeah,
coming from a private therapist?
yeah,
What's the source?
mhm,
And a lot of treatment centers are not tracking this.
mhm, yeah,
If you are a treatment center and you are listening to this,
yeah,
these are really important data points to
yeah,
be looking at if you want to be able to improve care and improve service
yeah,
overall. Annie's taking this data and making it usable.
yeah.
So, even if you're not submitting data to FORSE, this is something that could be really helpful.
Wherever FORSE goes in the future, helping people measure, helping them standardize, helping them use data effectively with whatever tool they're using, whether they're doing that for, compliance reasons, they're doing that for process improvement reasons, they're doing that to improve staff and patient satisfaction, whatever the immediate goal is, moving toward a place where we can really be considered like other types of healthcare, more in the research literature, that there's more research on real life treatment, wherever it occurs, that it's published, and that, people who make policies can look at that data and say, oh, here's what we're seeing about where people are being served and how they're doing. And I think both of us are working toward collect it, use it, understand it, and you don't have to do it alone.
Yeah, I remember I had a conversation with my daughter. She's saying, I'm having a hard time sleeping. Sleep isn't real good. Can you give me some ideas to help me with my sleep? I totally nerd out on this stuff. I've got the ring, I've got the watch. I track, I know every bit about my sleep. And that was probably why she asked me. I go, why don't you start tracking it? Make some changes bit by bit and look at your data, or I'll look at the data with you, but let's start collecting it. And unfortunately, we're still in an age where people are still collecting information on paper.
Yeah.
You can't do anything with. I can't tell you how many people are collecting information on paper. I'm shocked. It really is so important if you're going to modernize your business.
Can't even share the information across your staff unless they go look at a piece of paper. Yeah. Not to mention compare your data to another center.
Is there anything else that stood out like a hammer over the head going, wow, this is real surprise?
We're still analyzing the data, we're still validating the data, but some of the dramatic changes in symptom report in treatment, whether it's outpatient or residential, big decreases in depression, anxiety, craving, improvements in recovery capital, all the things we'd hope to see. We're seeing, wanting to get the data to a point where it's publishable and it's usable to advocate for people to get help, because that's, I think, what's most exciting. And seeing some of those centers out there who somehow have, really good post-discharge follow-up response rates, that they have staff their job is to follow up with people and find out how they're doing. And it's so hard to get a good response post-discharge from treatment, but really seeing what's happening to people, not just to get their data, but to stay connected and really look at this as a long-term illness and a long-term engagement, whether you come back to our center or you go somewhere else, that someone has their finger on the pulse, they're really trying to stay connected with people and really looking at some pretty dramatic changes as people are engaged with care. So that's really heartening, because a story that needs to be told about the good that happens in treatment. We often hear about the horror stories, and there are many. The transformations that happen in treatment, telling that story in data rather than just alumni stories is really exciting. So,
Annie, this has been really interesting. I was expecting to spend 15 minutes talking about FORSE and what you were doing with that. I know we're kind of winding down our time. I definitely want to bring you back on here and talk more about some of the other topics that we had planned.
Yeah, we had a whole list.
Taking the information that you got from this, what would you pass on to them to be able to offer better treatment?
I guess the top thing that comes to mind is don't do it alone. Join with others you trust, whether it's a vendor, whether it's, an NAATP and FORSE, or it's Hatch, or it's other providers, a provider group that you trust. Join together and start talking. How are you collecting data? How are you using it? How are you analyzing it? Who are you sharing it with? How do you share it back with patients and families and the public? How do you market with it? How do you advocate, for policy change with it? Don't think you have to do it alone. There's so many efforts out there. Join one. If it's the wrong one, join another one. Tell these stories together and make a big impact in addiction healthcare. There's a lot of work to be done, but so much more can be done when we do it in partnership.
So many times people are like, this is my little secret. There's no secrets. We all do. Every treatment provider or most treatment providers are doing the same or similar kinds of things. There definitely needs to be more data sharing and people being more willing to share information. It will make a really big difference. And I love that takeaway. Annie, thank you very much. I really appreciate it.
Yeah, thank you, Mike.
Thanks for tuning in to Hatching Creativity. We appreciate your support. Please don't forget to like and subscribe and tell all your friends about the show. And remember, it's never just about one thing.